Fantastic. All right. Happy Friday to everyone joining us. So welcome to our Baptist Behavioral Health Grand Rounds. We really appreciate your attendance. I'm Dr. Baralo Sims, Director of Education and Training. And before we begin, just a few notes on today's presentation. If you do have any questions, please submit these into the Q&A box or the chat. I'll be moderating that throughout, and any questions you put in there, we can hopefully have some time to talk with Dr. Galloway at the end. And at this time, if you are logging in through a mobile device that shows your number and not your Zoom account name, please sign into the chat with your name and your credentials. Okay. Now, please help me welcome our speaker, Dr. Galloway. Dr. Kristen Galloway is a fellowship-trained child, adolescent, and adult outpatient psychologist within Baptist Behavioral Health. She received her PhD from Louisiana State University and has been practicing for nearly a decade. Dr. Galloway believes that therapy is a balance of accepting things you cannot change and changing the things you can. She relies heavily on her background in dialectical behavioral therapy, or as you'll learn more about today, DBT, and value-based therapy. Dr. Galloway's areas of expertise include, of course, DBT, anxiety, depression, impulsive behaviors, and behavior management. Welcome, Dr. Galloway.
Thank you. Thank you all so much for being here. Like Dr. Sims said, I'm Dr. Galloway, and I'm so excited to talk to you all about DBT. It is a passion of mine. I enjoy it, and I'm still learning it as long as I've been doing it. I probably started doing DBT when I was an intern, and I'm still doing it 10 years, 12 years later now, which is insane. So I hope you get something out of today. I am a talker. I am a fast talker, so I'll try to slow down. But I am a talker, and I have a lot of good information that I hope to share with you today. So please put your questions in the chat. I will do my best to make sure that we have 5 minutes left at the end to make sure that we answer any of your questions. So I know we might have kind of a diverse crowd today, from people who maybe you're like, I know DBT, I just like having exposure to it. Maybe you're a person who's never heard of DBT in your life. Maybe you're somebody who's interested in DBT therapy for yourself and want more information. Maybe you're an indirect care provider and you don't necessarily do patient care, or you're not necessarily a therapist, and that is okay. I really thought about today, thinking about this talk, like, what could you take home? So I'm trying to think about everybody that could be showing up in the room today and feeling like, is there at least one thing that you'll take away? Whether you use that professionally or personally, because what I'll spend some time talking about today is, I don't just use this with the people I work with. I use this for me in my own personal life, as well as just being a better therapist. So I hope that you get something out of today. All right. So it would not be appropriate for us to talk about DBT without doing any kind of mindfulness activity. And when people think about mindfulness, I think they think about meditation, which is totally fine. We use meditation in mindfulness, but mindfulness is not just about meditation. And we'll talk a little bit more about that today. So we're going to do a mindfulness minute. So the beauty is I can't see you, so you can do this all in the comfort of your space and no one is looking at you. Okay, you're all just looking at me looking silly right now in about a few seconds. So what we're going to do is something we call a body scan. So I want you, just for a few seconds, to scan your body. Notice any tension. Just notice where you're holding your tension. Are your shoulders kind of tense? Is your tummy really tense? For those of you who have stomach issues, a lot of times we tense our stomach because we're in pain, or maybe we're anxious. Maybe you hold your tension like in your butt or in your legs or in your feet. Just notice where your tension lies. Okay, so take a second to do that scan. And then what I want you to do, wherever you're noticing that tension, just for a few seconds, I want you to intentionally tense that part of your body, right? So if it's your shoulders, or if it's like up here, you'd want to open your eyes really big. If it's your jaw, you really want to open that jaw, and you want to do it for a few seconds and release. So for me, a lot of my tension's in my shoulders. So I'll do a lot of high shrugs and just release. And all I'm doing is trying to work the tension out of my body. Because when we're tense, it's the #1 sign that our fight or flight is activated, right? Giving this talk and knowing people are listening to me, my fight or flight goes, woo, So I can feel the tension in my body. And so something that I'm trying to do is release that tension, because I'm trying to send a message to my brain and body, please turn off. I don't need you to be on right now. I'm not unsafe, because it's not good for our fight or flight to keep going. So this is by no means a miracle job, okay? This is not going to just be like, whoo, I feel amazingly, right? It is just a one way, easy way that we can just get some tension out of our body and get that regulation to just be a little bit better, not to feel so stressed out. Somebody once told me that we should stretch as much as cat and dogs. Like, think about how much they stretch when they move. And so I think about, this is something you do every day. Maybe you're in between patients, even sometimes if you're sitting with somebody. I do it all the time with the people I work with. We do progressive muscle relaxation. It's just a way. I hope you're just feeling a little like, and I can just, breathe, stretch, whatever you need to do. Just kind of bring that stress down, get rid of whatever you came into the room with, and just try to be as present as possible with me. Okay, hope that was helpful. So just to know a little bit about mindfulness before I go into too much detail, we use mindfulness for everything. We use it for individual therapy, group therapy. If I'm doing supervision or a consultation with colleagues, we always start with mindfulness, because we have to set the tone that we're here, you're here right now. You hopefully will get some good information. I ask that you be open-minded to what I have to share, and I hope that you leave with something really positive that you can take away. So thank you for participating in that activity. Okay. So in order for me to give you some foundational information about DBT, you have to kind of understand why it was created and who it's useful for. So one thing that you will walk away with today is, who is this for, right? So if you're somebody who's looking to work with certain people, or maybe yourself are considering different types of therapies, this will be great to say, okay, who's a good fit for this? So DBT was started by a person named Marcia Linehan. Marcia started off her career in CBT, in cognitive behavioral therapy. I think people are pretty familiar with that. So I'm going to give you a quick little history lesson. I know this was not like part of it, but you get a little history lesson today. So psychology is so confusing. I don't know why we make it so confusing, but it is. And there's lots of branches of psychology. And so one of the branches specifically that we're talking about today is behaviorism. Okay. And behaviorism was started by a guy named P.F. Skinner. He's the godfather of behaviorism. And he said, maybe we can influence behavior. Like, maybe the variables in the environment are affecting people's behavior. And if we change those variables, we can change the behavior. Great information. So then comes along a few other guys, and they say, wait a minute, but I think thoughts and feelings also play a role in our behavior. So maybe we should consider that. So then they're like, there's this thing, CBT, cognitive behavioral therapy, what I think a lot of people are familiar with. So then the third wave of strategies, it's called the third wave of behaviorism, came around, and Marcia came around and created DBT, and we'll talk about how that happened. But just so you know, if you're interested, there's also two other styles of therapy that are in that third dimension. So ACT, acceptance and commitment therapy, as well as FAP, functional analytical psychotherapy. I think they're a little less well known, but they're phenomenal strategies. So just your history lesson for today. I like to nerd out sometimes on this topic. So Marcia was doing CBT. And what she realized was she was working with mostly people who have borderline personality disorder and or were really struggling with suicidal behaviors and parasuicidal behaviors. In the DBT world, we consider self-harm suicidal behaviors. For a lot of people, self-harm is just self-harm. But in this collection of behaviors that we'll talk more about, this will make more sense soon. Self-harm is usually more of a parasuicidal behavior, where it is still in that umbrella of suicidal behaviors, okay? So it's these people who continue to go inpatient, continue to have suicide attempts, and they're not getting better. And what she found was CBT just wasn't the right fit for them. There's really great stuff for CBT. CBT is wonderful. Okay. So if you do CBT, if you have, if you're going to therapy and you're getting CBT, that's great. It's a great therapy. But she realizes that people in this specific population really needed more. So she didn't throw away CBT. She was like, okay, the CBT stuff is good, but it's missing some things. And so what she did, which I think is brilliant, and I'll talk a lot about that as we go on, is that it's not that a lot of the things she did was new. She just put it together in such a beautiful, it's like there were all these puzzle pieces and she solved the puzzle and she found a way to utilize this so it's helpful. So she still said, okay, the CBT stuff is good. I don't want to lose that. And then let's consider acceptance-based strategies, mindfulness, and meditation, right? Because there's lots of wonderful therapists out there that are just good therapists. They're just good people, right? They're just good at validation. They're good at being in a room with people. They're good at listening. But the problem with CBT is it wasn't in the model. It wasn't part of the model to do validation strategies, to understand how to show up accepting, to have acceptance-based strategies, because CBT really is a lot about change. And there wasn't this balance of acceptance and change. And the problem with that is there's things in life that we can't change, right? I can't bring back a loved one. I can't take away certain diagnoses. I can't create a treatment that doesn't exist. And so she was recognizing that people were suffering because they didn't know how to deal with these things that they can't change. Okay. So she realized that that part was important. And then she also added the dialectical philosophy. So dialectics have been around since the beginning of time. That is not new. She just found a way to incorporate that into the therapy room. And that is really the bread and butter of DBT, is those dialectics. So we'll learn more about that. Okay. I giggle for two reasons. One, it's a very bizarre thing to talk to yourself this whole time when you know people are there, but you have no idea how they're reacting. So I just want to throw that out there. And two, the biosocial theory is very heavy. Okay, it's a very important piece of DBT. We're going to talk a little bit about it so you have a general understanding, but we're not going to go into the nitty gritty because it could take the whole hour. Okay. So we know dialectics is important. We know CBT is important, and we know acceptance-based strategies are important. We know those things. The other thing that she recommended was she believed that a lot of people that DBT would be effective for is people at the heart of their issues are emotionally dysregulated. And one of her hypotheses as why those people are dysregulated is because of the biosocial theory. Okay, so what's the biosocial theory? It's exactly what it looks like. Bio is affecting social and social is affecting bio. Okay, so what do I mean by that? Actually, let me back up before I show you that slide because it might get a little confusing. So her belief is that there are some people on this planet that are born, right? It was not anybody's fault. It's just a genetic predisposition to a higher sensitivity to emotions. Not that they're emotionally sensitive, but that for whatever reason, when I experience an emotion compared to when this person experiences emotion, it feels like this, where it feels like this on me, right? So for whatever reason, it feels worse. So think about it almost like a pain tolerance. It's not that they necessarily have like a low pain tolerance, it's that they experience these emotions at such a high velocity to where it's really hard to deal with, okay? So they have a high sensitivity and a high reactivity. So if I'm really sensitive to emotions, right? I have that threshold that's hard because my emotions are big, then I'm going to have a high reactivity, right? Because that kind of maps. And then I have a slow return to baseline. Because if you can see if I'm reacting and having big emotions, the likelihood for another emotion and interaction to come along or to have a poor reaction to an emotion that elicits another negative reaction, it's really hard to regulate, right? So this is idea that there's already this biology that kind of sets the tone for dysregulation. And there's a history of invalidation. So something in their environment over years and years and years has been invalidating. That might mean having abusive parents or experiencing neglect. It could also mean a mismatch, because sometimes when you're describing the biosocial theory, especially with adolescents and parents will feel like, oh my gosh, did I do something wrong? Is this my fault? And the answer is absolutely no. You didn't do anything wrong because you were just trying to be the best parent that you knew how to be. It's just that there is a mismatch in the way these things are handled. Minor example, we do this all the time. We're so invalidating to people all the time, unintentionally, right? Where, perfect example, I have a toddler, I have two toddlers. And my toddler last night was upset because, we do a treasure box and he didn't earn what he wanted to earn. And I think my reaction, because it's hard for me to tolerate his disappointment, is to shut down his emotions. Like, it's not that big of a deal, Ollie. Why are you so upset? But if he's feeling that and he gets that message from me that his feelings aren't valid, and let's say I kept doing that over and over and over and over again, he's going to be like, do I not know myself? Like, maybe this isn't a big of a deal. Maybe I am overreacting. So sometimes we unintentionally send that message to others because we're trying to tolerate our own distress, right? And so that wouldn't necessarily make my son dysregulated, but if that kept happening to somebody over and over and over again. The other important piece of this too is, even if I'm acknowledging and validating someone's emotion, it doesn't mean that I validate the behavior. And that's something we talk a lot in DBT, is that you have every right to feel the way that you do. It does not give us permission, though, to do whatever we want to do. Very dialectical statement, right? So we talk a lot about like feelings and actions, very different worlds. So what does this look like in the therapy room? How would this look like for an adult struggling with this biosocial theory? Okay. So somebody comes into the room and they're telling me about an argument they had with a significant other. And they're telling me they were upset about something and they used appropriate skills. They went in using interpersonal effectiveness skills and they expressed their grievance to their romantic partner. Okay. So good coping skill, helpful coping skill. Partner comes, oh my goodness, y'all, my computer just locked up. Hold on one second. At the end of this, we'll talk about riding the waves of emotions. And this is a great opportunity for me to ride that roller coaster and just let it happen. So, okay, so they come in upset about their partner, okay? So then their partner, they express it appropriately, but then their partner says something like, like, you're so ridiculous. I can't believe you're so upset about this. You're so stupid. I don't know why you brought this up. Well, somebody who's been struggling with this for a long time has those thoughts and goes, am I stupid? Like, maybe this is stupid. I mean, I think we've all kind of been there when somebody challenges us, when we bring a grievance, we're like, well, maybe I am, maybe it isn't a big deal, right? So they start to question that, right? So now, instead of using appropriate skills, they might now lash out, and now it's a full-on fight. And this goes back and forth, back and forth, back and forth until their partner goes, I wish you were never born, right? And so now, even though they might appear in control because they're also engaging in this verbal aggression, that just tears them apart, right? And then they might end up engaging in self-harm or suicide attempt because they don't feel good enough, right? And so I'm describing one incident that happens over years and years and years and years that leads somebody to be highly dysregulated, okay? So I think the dialect of a lot of people who are dysregulated is sometimes they show up as well managed because they can handle conflict, but they are tearing themselves apart inside. Okay. So this is kind of how it happens. So we have that biological influence, which then is met with influence by the environment, which affects behavior. And it's this whole cycle. And so what happens is it leads to this, inability to trust themselves. So everything becomes external. I no longer can trust myself. Everybody's telling me I'm wrong. So I must rely on you. So if you're ever in the room with someone like this, or you have, maybe there's somebody in the room today diagnosed with borderline, it's hard because there is this sense of like, I can't rely on myself. I have to rely on other people. And it becomes extremely challenging. Or we engage in impulsive behaviors because we're so emotionally dysregulated that it leads to impulsivity. You can see how this leads to conflict. And so what Marcia did was, around all of these areas that there are problems, she developed skills. So all of the problems caused from the biosocial theory, these interactional effects, she now found a skill base to help people utilize these tools so they stop hurting themselves. Because ultimately, the biggest form of invalidation is self-harm and suicide attempts, right? Like, I'm saying that, like, I'm hurting so bad that I don't matter to be here anymore, right? And we don't want people to do that anymore. So part of this model is helping people work towards a life worth living. That is our true goal. The other thing I want to briefly mention is we handle suicidal behaviors a little bit differently because of this. Because what happens is behavior gets reinforced unintentionally, right? So as a quick example, somebody can be in an argument, it's going. The person threatens to break up with them. They go, I'm just going to kill myself. And maybe they said it on purpose. Maybe it was an emotional reaction. Maybe it was impulsive. Maybe it was true. But what happens a lot of time when we do that as a society, when somebody says that, our natural inclination, rightfully so, is to then go, it's okay, we won't break up. Let's figure this out because I don't want you to die, right? But when someone has a chronic history of suicidal ideation and those parasuicidal self-harm behaviors, what happens is we unintentionally reinforce those behaviors. So when you're doing strict DBT with somebody, you want to make sure that we have to notice the variables. So the example I gave earlier in the person talking, they used an appropriate skill. They expressed their grievance using interpersonal effectiveness skills, yet it was met with punishment. So then they throw that out, right? But then if they were to say, hey, I'm going to kill myself, that becomes unintentionally reinforced. So you have to be very careful. And I'll talk a little bit more about that here soon. So that is your brief introduction to the biosocial theory. It's a heavy thing, but I hope that you got something out of it. Okay, this is such a great line that Marcia has. Borderline individuals are the psychological equivalent of a third-degree burn patient. They simply have, so to speak, no emotional skin. Even the slightest touch or movement can create immense suffering, right? And this is very helpful for me because I think about sometimes when this person is in the room, they need you so badly because they feel so abandoned and their locus of control is external. And sometimes they can lash out on you. You know, I get lashed out on all the time. And it's hard. And I express that in the room and we work through those behaviors. And it's also helping me recognize that, like, this is hard for this person, you know, and something that typically might not, you know, be hard feedback for somebody else is probably incredibly hard for them to tolerate because they already feel worthless. So when we give what we think is just typical feedback, that can be really challenging for anybody that's extremely dysregulated because they're really struggling with that sense of self. The other important thing to know is that Marshall Linehan actually struggled with her own mental health issues and her own suicidal ideation and behaviors. And so when she was creating this, it wasn't just for people that she wanted to help, it was also for herself. And I tell people that DBT is a very transparent therapy. Everything I'm telling you right now, I would tell to somebody I'm working with because it's not all this information I'm just trying to keep hidden. It's all this information I want to share to people to help them understand themselves and get better. And Marsha Linehan is such a great advocate and also role model for people who struggle with this because she got her PhD and created a therapy. I mean, that's pretty powerful. At least I think so. Okay, so who is this useful for? I think this is like an important question that people have. And really, I mean, the research has exploded over the last 10 years. And so you can almost say a significant amount of the populations that we would work with would fit. So obviously borderline personality, because that's really what it was created for. So a lot of times people who are borderline, it would be good for them to do traditional DBT. People who are frequently in the hospital. So like I was saying earlier, and this is a hard discussion without context, but if you have somebody who's borderline and they are having consistent suicide attempts, we try to avoid the hospital because the hospital is unintentionally rewarding. For most people, they don't like it because it infringes upon their freedom. But for somebody who might be borderline and has a low support system and lack of care and people are negative to them, going to a hospital where they get art therapy and groups and hot meals and a warm bed, it is actually reinforcing. And we don't want to reinforce suicidal behaviors. So as a DBT therapist, I use the hospital when it's an absolute safety concern. I feel like there's no other option. But for this specific population, I'm not talking about other people here, just this specific population, we really try to avoid the hospital and do something what we call phone coaching to shift from reinforcing suicidal behavior to calling me and problem solving. So I reinforce resilience and say, you could do this. Let's work together. Let's find a way not to hurt yourself. So anybody with suicidal behaviors, parasuicidal behaviors, even just self-harm, like a traditional self-harm would be a good fit here. Eating disorders, ADHD, mood disorders, PTSD, dysregulated adolescence, autism now. The skills are highly beneficial for someone with autism. It meshes really well because there's a lot of structure in the model. So there's a lot of people that this helps. The one caveat I will say about PTSD is that you never want to do PTSD work unless they have gone through all the emotional regulation skills. They need to know how to ground. They need to know how to identify safety cues. They need to know how to identify triggers, because if we start doing trauma work with somebody who's dysregulated, we can put them in a dissociative state. They can start having more flashbacks. It could be harmful rather than helpful. So you always want to make sure that person is regulated and has those tools and grounding before you do any PTSD work. So at the core of this, when you ask, am I or anybody else in my life or my clients or my patients, who's a good fit for DBT? At the core of the issue is emotional dysregulation the issue. Are they struggling with emotional dysregulation? This is a good fit for them. And, thinking about, are they not responsive to CBT? Are they needing more of that balance? This might also be a good fit for them. Okay, our bread and butter, dialectics. So I'm going to work really hard to not nerd out, be mindful of time so that we could get through everything, but I could spend a lot of time talking about dialectics. So as I said, dialectical philosophy, nothing new. Okay, she's added it to her therapy. So the idea of dialectics is two things that are opposite that appear counterintuitive. So two things that are opposite, you would think that's a problem. If I feel this, if I'm sad and I'm mad, or I'm sad and I'm happy, like that would be counterintuitive. Not necessarily. So we take two things that appear to be counterintuitive, opposites, and we find a new truth called their synthesis. So what does that mean? Why is that important? Why are we using all of this verbiage? The idea is that people who are emotionally dysregulated, and when people are in a heightened state of emotions, they make rash decisions and they get stuck on the poles, right? We're seeing this in politics right now. I won't go into politics. I would love to go into politics, not to tell you my politics, but dialectics are very helpful in politics. Then the reason I say that is you can see how it's like, we have to pick this team, right? It's like either I have to value my finances or my privacy, or that people aren't homeless. It's like, I feel like I'm on all those teams, right? I feel like I want it all. And that's what dialectics would say, that you don't have to pick a team, that all of these things are true. But what happens is people are like, I have to stay with them or I have to break up. I have to quit my job or I have to stay. And they miss all of the opportunities, what we call the middle path, to find a solution, because there's more than two options. So we're trying to move people away from the poles and go, what if two opposites are true? I was having a conversation with somebody the other day who's struggling with a partner with chronic illness. It's had a really rough effect. It's significantly changed their life. And one of the dialects we were working with was like, I think you can accept the reality today that this life is hard and this life has changed and it's incredibly hard for the both of you. And that does not mean you have to accept the reality of the future, that we can still remain hopeful about what the future brings, that you don't have to just stay on one team, right? That you can all of these things. And for adolescents, I think this is really good for them as they're going through their identity crisis. It's look, you don't have to be sporty or girly, you can be all of those things. You don't always have to fit in this box. And so it's extremely valuable in the therapy room for problem solving. So what does it do for us? Well, it helps us look at the situation more, right? So if I'm able to see all of it and I'm willing to accept all of it and look at the whole picture, not just this one way of thinking about it, I'm going to be a much better problem solver. I'm also going to feel like there's a way out. Because with people who are suicidal, they feel like that is the only solution. Most people get suicidal not because they want to die, but because they feel like that's the only choice. And what we do as professionals is we get so stuck on keeping people alive, we don't spend enough time figuring out why they did it in the first place. And if we do something called behavioral chaining in dialectics, or in DBT, where we look at all the variables that led up to that decision, and we're able to manipulate those variables so it doesn't happen again, right? And that's a process that happens over time. It's not a one and done thing, right? But our goal is to make people feel like they have choices, right? Because they're feeling like they don't have any choices. So our goal is to see there's all these choices, there's all these problem solving that you can do, because the brain shuts down when it doesn't feel like it has a solution. And that thought will naturally show up if I want to die, because it feels like that's my only option to get rid of this pain. So we really work on giving people solutions. It allows to not get so stuck and rigid about a perspective and recognize, even if I don't agree, we talk about that a lot, I don't have to agree, I just have to recognize it's valid, right? So I don't have to agree with you, I can just recognize that your opinion is valid and makes sense. The other things that are really important to consider is that change is always constant. And I bring this up because people really get stuck on the outcome and not the process. I will not always get what I want, right? Like I could advocate for a raise all the time. It doesn't mean I'm going to get one, right? So I can't always look at the product of my progress. I have to look at the process. So I'll give you an example that's more relevant. I was talking to somebody and we were making a decision about what they were going to do in the relationship. They decided they wanted to move towards working on it. They made some changes. It was successful. A month later, they break up and they tell me, that was stupid. That wasn't worth it. See, why did you tell me to do this? And I said, wait a minute. We didn't have that information a month ago. At that month, you wanted to stay in the relationship. You were skillful and it was successful. And now change happened. Variables happened. It's all new information. We have to go back to those dialectics and find our new truth, because there is no absolute truth, because change is constant. Right? So it's getting people off of this whole product thing and be like, well, you were skillful. That's the important. You're a better human. You're better at living. You're doing all this really cool stuff. And the better you are, the better the outcomes. We can't just always get 100%. I mean, we can't just bat 1,000, but our batting average is better the more we're skillful. Okay. It allows these opposites to be true, and it helps honor the truth of the situation. So I'll give you a personal example because I kind of talked about how you can use this personally. So I'm married, been married for 6 years. And if you're like us, and maybe you're not, you know, when we get into it, it's all about me and it's all about him, right? So I'm like, well, I feel like you did this and I need you to do this, right? Or we get stuck in the, you know, babe, you're so wonderful at doing these things, but like you really suck at taking out the trash. So could you do that? Like we don't really think about how to approach our partner in an effective way. We don't honor the other side. And what happens sometimes is we get so wrapped up in just trying to tell people our intentions, which I don't think people want to hear from us. I don't think they care about that piece. They just want to feel heard. So when my husband and I argue, it is a work in progress, what I try to do is add dialectics. Instead of saying but, I use the word and. So I might say to him, you know, baby, I do appreciate all the things you do. I see you with our kids. I see you, you know, doing the dishes. I see you taking out the trash. And I could really use some help with the laundry, right? So I am validating his experience first, and I'm not negating it with a but. I'm saying, and I still need help. So I'm trying to be understanding while also getting my needs met as well. Okay. So Marcia was very wise when she thought about this type of therapy. I mean, dialectics run through this whole thing. It still blows my mind, just the levels of dialectics through this. So what do I mean by that? So she constantly balances these two things. So we're balancing acceptance and change, not only as a therapist, but also for the person in the room. So again, this probably isn't new if you've ever done AA or had any experience with AA. This language is going to sound familiar. So what we're doing in the therapy room is not just focusing on change, right? That is a piece of the puzzle because it's helpful to change things that are changeable. And we also focus on acceptance because, like we've talked about, there's things I can't change. Where people suffer is the opposite. A lot of times they're struggling to accept the things they cannot change, and they're having a hard time changing the things that are changeable. So we're always working towards that. As a therapist, I try to balance that myself. I try to be accepting and validating and genuine and honest while also pushing for change and challenging people, right? And if I'm doing more than the other, I feel it in the room. Because if I'm being maybe too accepting, they might start to feel hopeless that like we can't change anything. And if I'm being too pushy about change, they might feel invalidated because I'm not noticing the things that they're doing well. Right. So we're always kind of having to make these two balances. So as you know, for the therapist in the room, thinking about that dichotomy and how you can balance that in the room is very helpful for people. Learning how to be nurturing with challenging. I relate to this as a parent, right? So I'm consistent. I have consistent expectations. But I'm also going to love you and I'm going to care for you. You know, so I make it a point to tell the people in my room, I care for you. I care for you so much. And part of my care means telling you things that are hard. And when I think you're not doing what you can do because I know you and we've worked on that relationship, I'm going to challenge you to do a little bit better. Right? Or if you committed to having a life worth living and you start engaging in behaviors that aren't towards that, I'm going to challenge that while also still saying, and it's hard. I know it's hard. So it's this constant balance of dialectics. That flexibility with stability. So again, consistent expectations while also being flexible to the person in the room. And then I really want to make sure I'm focusing on both either things people are doing well and building on that skill set, while also being mindful of things that maybe are a can't do versus a won't do. Because a can't do means we need to teach skills. A won't do mean there's some resistance, and we would challenge those much differently. So being aware of building on people's skill sets and building on their strengths. So you can see as the way I'm talking, it just, there's like a freedom. Like I feel like it's like a breath of fresh air in the room when we're like, we have all these possibilities. Not all the possibilities are good, but we have all of these possibilities that now create space for hope, right? And that's ultimately what we're trying to do. Because I don't want you to just live. I want you to have a life worth living. That's my goal. I'm not just trying to keep you alive. I want you to love the life you have. And we just need to figure out how to get there. And it's going to be hard. And you got to work just as hard as me outside the therapy room. But if you're willing to do that, you can have a better life. Okay. So just a little bit more, I kind of already used the example of the I feel statements. I think we sometimes use I feel statements, but they're more I think statements and we say I feel. So don't underestimate I feel statements. Again, accepting that different options are valid. That's hard, but it's true. Checking your assumptions. I tell people all the time, I'm not a mind reader. You are not a mind reader. Just because that lady had that resting face doesn't mean that we can assume that that's what was going on, right? We don't want to respond to that. We want to check the facts. So we can't assume things, right? Because then we're acting out of that assumption versus our reality. And then a huge one is like, look, and my husband and I talk about this all the time. Like we've known each other for 8 years and he's the person I know the most, but I still can't read his mind. So we got to tell people, we can't assume they know. Really important. So again, we already kind of talked about this, really noticing to use those and statements, right? So I'm sure this is really hard and I know you can do it. I know you didn't create all of your problems and you're still the person that needs to solve them. If you were to the point in your life where you feel like you are going to physically hurt yourself, inflict pain, have blood come out of your body, have to have a stitch on your body, I cannot even imagine the pain that you're in. And I do not want you to hurt yourself because that's invalidating. So we got to figure this out. Right? They're both showing up at the same time. And I genuinely believe that I have this extreme empathy and I've got to teach you how to change the behavior. Both are true. Okay. And the biggest thing that you take away from this that I think is helpful for people is like, no one's right and no one's wrong. Like there's no right. And as a science practitioner, I think this is very freeing. I'm very aware I'm teaching you a therapy that in 10 years might be old science and there will be a new truth and even better therapy, or who knows, maybe this will still be great. I hope it is because I love it. But you have to kind of accept that the truth is always moving. The pandemic is such a great example of that because we can look back in hindsight and say all of these things, but we didn't know that then, right? And so now that we know more, the truth is always changing. Right? So even in her skills, I mean, like I said, I can nerd out. So I apologize for nerding out on you guys, but the dialects are all the way through. It's how you show up in the therapy room. It's in the skills that you teach people. It's in the skills that they'll learn in the group. I mean, there's just dialectics happening everywhere. So even in the strategies we use the CBT, which is the change-based strategies. And then we also balance that with validating strategies. So this is going to seem very much like CBT. Some of the things we do, we generate solutions. We do a lot of problem solving. We do contingency management. So like I said, trying to reinforce helpful coping strategies and trying to not reinforce unhelpful behaviors. We do the skills training, which I think is kind of what everybody knows when they think about DBT is the skills group. We do exposure-based therapy, not only to things, but to emotions. Shame and guilt are one of the hardest emotions for people to manage. So we have exposure sessions to those emotions. And then that cognitive modification, we'll talk a teeny tiny bit about wise mind and getting people, if they don't have a sense of self, to learn how to trust that gut, right? They need to learn how to trust their gut feeling again. Validation is so underrated. I could spend the whole time on this too today, but I won't. I won't do that to you guys. Don't underestimate your ability to validate somebody on the street, somebody in your room, a coworker. It is the greatest gift you can give somebody. You don't have to agree with them. That's not the goal. The goal is to have them feel heard and understood. And validation looks different for everybody else. So I think it's really important to ask the person in the room what kind of validation that they want. So I'll give you two examples in my personal life where I felt extremely validated. This was many moons ago. I was in a relationship. I was engaged. It's like, I don't love you anymore. I was gutted. Like, you don't love me anymore. I'm obviously okay at this point, but at the time, it was awful. It was the worst event in my entire life. I didn't know what I was going to do. I had no plan. And my sister called me. And in context, I think this is helpful. I tease her that we have an empathy tree to teach her empathy. She's not the most empathy. We're very opposite, very opposite. Anyway, I bring up that detail because when I called her to tell her what happened, she just cried. She just cried. And that was so impactful for me to just have somebody totally validate how I was feeling, that she couldn't even have words because she hurt so much for me. And sometimes in the session, that's helpful. Not that it ever becomes about us, but just having tears with somebody being like, I hurt. I care about you and I see you hurt. And this is my reaction, is to be tearful. Okay. My other great validation, and I bring this up because it's so opposite than what you think. So I'm making my phone calls and I'm like, the 20 phone calls you have to make of like, we're not getting married, blah, 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 blah. And my friend, his name is Mike Jones. I don't know if you know, Mike Jones is a rapper. So, if you're named Mike Jones, we have to call you Mike Jones. And so Mike Jones calls and I'm telling him, and immediately he goes, well, let me tell you about my day. And it was the first time I laughed since it had happened because I knew what he was doing. He knew me well enough. He knew I was making those phone calls all day. He knew I'd been crying my eyes out. And so he just wanted to distract me. And it was so validating. And so don't underestimate the power of validation, and always ask the people in your life who you love, what do you need? How do you feel validated? How do you feel heard? How do you feel understood? Because everybody's different. And it's such an important thing, because the second someone feels understood, they're so much more open to understanding you, to problem solving. So if somebody in your room is being resistant, it's probably because they don't feel understood, right? So we just have to keep digging. Okay. So just briefly, there's several different strategies. We've talked about 3 of them already. There is some case management and stylistic stuff we do. I think that would be for, a second presentation if you guys ever wanted it. But there's several different strategies that we use throughout DBT. This is just an example of what standard DBT would look like. It's very intense. I wouldn't recommend it unless it's somebody maybe with borderline or struggling with really at-risk behaviors. I think people can get a lot out of DBT strategies without doing standard DBT. I think this would be a lot for someone who maybe isn't struggling with those at-risk behaviors. The other thing, like I mentioned, the phone calls, we do it differently. Typically if someone's suicidal, we encourage them to call the crisis line, right? And that's great. We want them to reach out for help. For people who are dysregulated and this becomes more of a reaction to dysregulation, we actually encourage them to call with the solution. So people will call me and say, hey, Kristen, I thought I was going to self-harm, but, I'm thinking about using my distress tolerance skills, blah, 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 blah. And now I'm reinforcing and building that resilience of like, yes, you called, that's awesome. And they get this final experience of people reinforcing helpful behaviors. So that's how we go about it a little differently. So again, Marsha, in her beautifulness, when you learn the skills, I don't know if you know this, 2 of the skills are acceptance-based and 2 of the skills are chain-based. So wise, so wise. Okay. Last nerd out moment, you guys. So the other thing is all of those things in the biosocial theory that we mentioned all have a skill. I don't trust myself. I learned how to be more mindful of my values. I'm impulsive. I learned distress tolerance. I'm dysregulated. I learned regulation. I have conflict. I learned interpersonal skills. And then for teenagers and families, we do this thing called walking the middle path. So she was so wise and thoughtful about how to utilize these skills. Okay, so what I thought I would do for the last 10 minutes is just briefly go over some skills, okay? So of each module, I'm going to give you just one brief overview of the skills. So you feel like you maybe could take this home with you, especially since you have the slides. So the give skills, it's not a what, it's a how. So what I would do is if the goal is to maintain the relationship or de-escalate conflict, we'd use the give skills. How we would do that is we would focus on being gentle, acting interested. For kids on the spectrum, that could be very difficult if it's a topic they're not interested in. Learning how to validate and utilizing an easy manner. So we would be mindful of these things. We would role play. I would be them first. They would be the other person. They would give me a hard time. I would practice showing up as them, and then we'd switch. They'd be themselves. I'd be that person. We do this over and over again until they feel comfortable. Then they go out in the world and use it. We come back, see what worked, what didn't work, and we go on from there. Pretty simple, not something that's like brand new, but great for people to practice. They're very resistant to role playing, but at the end, they will thank you. Say that was helpful. Okay, love distress tolerance. Distress tolerance is great because it's this idea that in our society, it's not okay to not be okay, but it's okay to not be okay. And this is distress tolerance. So it's the idea that I lost a loved one, had one of those acceptance-based events, and I'm not going to feel better. I'm just not. I went through this horrific event. I had that breakup. I was not going to feel better. So this is just doing the thing that you need to do to not make the situation worse, right? Because we feel the emotion, we act impulsively, creates worse emotions, we act impulsively, blah, 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 blah. So this is a survival tactic. We are just trying to get by to not make it worse. And I think just telling people that it's okay to not be okay, that it's okay to just feel the way that you do is very liberating, because people feel pressured all the time to just be okay. When we're human. So real quickly, this is if you knew a problem ahead of time. So let's say when I get dysregulated and I'm overwhelmed, I use drugs. I love this with teenagers because it's the first time someone asks them, what are the positives of using drugs? Because guess what, y'all? Drugs are fun, some of them. So it's good to speak that into the room because it's honest, right? If the goal is still to stop them from using drugs, but it's important to speak that into the room. So what we would do is we would sit down and go, okay, tell me what are the pros of using drugs? There's got to be some, right? Tell me the con. Then we would go, okay, let's say our distress tolerance skill is reading a book. Okay, probably not, but we'll just go with that. Tell me the pros and cons of that. Okay. So then what we would do is then say, tell me the short-term and long consequences of each. And then I want them to look at it and tell me, what do they think? And lo and behold, what they will notice is that the pros of tolerating distress are long and the cons are short. And the pros of using drugs are short, but the cons are long. And so they have this aha moment of like, maybe it's not worth it. Like maybe if I can just get through the moment, I can tolerate distress. So this is something we put on like an index card and have them remember to utilize when they have that urge. It's not going to be 100%, right? It's not going to be like foolproof, but if they just thought about it, if they pulled out the card, you are making a change. If you are doing this yourself, right? Like if you're trying to do the pro and con of tolerating distress versus doing your impulsive behavior, if you thought about it, you're making change, and that's great. Okay. I think what I like to do is I'm going to skip this one because I kind of want to just do the wave skill real quick. It's a mindfulness skill, and we can end with that. And then y'all can ask me any questions that you might have. Okay. So if you're comfortable right now, I invite you to close your eyes. If you're not comfortable, just look at the floor in front of you. And I want you to just pick an emotion right now that you've been struggling with a little bit, maybe some irritability, some tiredness, maybe a little lower mood. I want you to just imagine it for just a second. And I want you to then imagine yourself walking on a beach. You get up to the water, you start to finally feel the water. You might pull back a little bit because it feels a little cold. You keep walking in. Starts to feel maybe a little rough, you're having to pick up your feet more. You keep walking. It's like you got to kind of jump, through the waves. And then you finally get to a place to where you can almost like float in the water. Imagine yourself just floating there and noticing that emotions are like waves. They come and they go. Might feel like hardly anything sometimes. Might feel like it's really hard to get through it. It might even feel like a tsunami at times. But remember, whatever that emotion is, it's going to come and it's going to go. That whatever you're feeling, whatever feeling you're feeling, that maybe you're even resistant to feeling, that if you allow it to come, it will go. And just like waves, they come and they go. The great thing is you are not the wave. You're on the wave. This emotion is not you. It may be hard. It may be difficult. You may have to sit with it for a minute, but at some time it will pass. And so as you're thinking about your emotions today, I want you to remember that they're going to come, but they're going to go. When y'all are ready, you can open up your eyes. And I hope that you enjoyed that. I know I did a little bit of a speed round towards the end. I wanted to make sure that you got some good information there. I can talk a little bit more about opposite action, or I can just answer questions, whatever you guys are feeling.
Thank you, Dr. Galloway. Really appreciate it. Yeah, so if anyone has follow-up questions for Dr. Galloway, please pop them into the chat or in the Q&A box. I'm going to pull up something, hopefully it allows me to, which is the CME information. And it looks like, because I'm not the host, let me reclaim it. Let's see if it lets me. Okay. So sorry, it knocked off yours, but here we go. So for those of you who would like to get CE credit for this, please do scan one of these QR codes as they're relevant to your discipline. I want to make a note. It's important to share that the CE granting process is not instantaneous. And so typically, just to give you all a sense of the timeline, it could take upwards of a few weeks, if not a month. So if you don't see on your CE broker transcript the credit reflected, email the email that's been popped into the chat, behavioral health education at bmcjax.com, and we'll investigate that with the discipline who's responsible for entering those. We do not enter those directly. It's different chairs all throughout the hospital, but I'm happy to facilitate that connection for you. For the CNAs in the room, I know you all potentially do not use CE broker, so just email, our contact, and we'll get you a certificate, which is not for a board, but I know you need it for the Excel program for records. Not a problem. Okay, let us know. So one question, Dr. Galloway, for you is from Melinda. Might be a typo, but maybe related to the age range. How young? Okay, so how young can DBT start? So what would be like that, low cutoff in terms of age range?
I would say adolescence, because you got to think about how the brain's developing in that prefrontal cortex. That's why adolescents really struggle with decision making, because it's not totally developed. So I would say, it's really hard with little bitties because dialectics is a difficult thing to understand. So I would say typically by adolescence, it would be a good fit.
Okay, yeah, that seems definitely reasonable. And so Christine Cruz, one of our BBH own, asked how we can get additional and longer DBT training as providers.
Well, I can say if anybody's interested, so I believe it's the second Thursday of every month at 8 a.m. I offer a consultation. We have different topics that I do. It's really people were interested, and so I just started doing it, and it's growing. So I typically teach. Right now we're on the fourth consultation on dialectics, and then I typically teach a skill, and then we do a thought for the day. So that is an opportunity. And then obviously through behavioral tech and Marsha Linehan, there's a lot of great resources out there too.
Definitely. And Elaine Davis, to your question as well. So those resources that Dr. Galloway just noted and behavioral tech, they do offer, webinars and things like that as well, don't they, Dr. Galloway? Small,
Yes.
shorter trainings.
Yes.
Mm-hmm.
Yes. So there's like the full training that you can do if you really want to be like a DBT therapist, but they'll have different segments like PTSD or eating disorders and those kinds of things if you're interested in a specific content area.
Okay. And so there are people asking in terms of DBT therapists in, the Jacksonville community, because you are an N of one, right? In our group, which we're trying to expand through rolling out some group programming, but it's not open to everyone just yet. We're, kind of in this pilot phase, recognizing that DBT is something that people would really like to offer their patients. But do you have recommendations related to potential referrals in the area?
Yeah. So I'm actually trying to build that now. I would say Allison Ventura at UF is doing an adolescent DBT program, which is great. And she's also trying to collect resources in the area. So we keep communicating. I know there's several groups going in the area virtually or in person. So honestly, a lot of it is Googling, but maybe at some point we can put together like a master list of resources so that people have them. That's a good thought.
Yeah, that would be fantastic. In terms of, DBT research, and everyone who is on the call definitely felt, your passion and excitement and, really investment in DBT as a theory. Is there any areas that you feel need more research?
People who are just anxious, and I say just not like that's like minimizing it. I mean, only have anxiety, seem to be the least responsive to this model. And so to me, that would be an interesting research question. What is going on? Why is this not as effective? I mean, I have my own thoughts, but that is, it's not been researched. So that to me is an interesting question as to why is this not mapping on? Because I can see a lot of value to some of this with people who are struggling with anxiety.
Yeah. Certainly. And Dr. Andrews made a note. So yes, we are offering DBT groups through our Bridge program. And I just wanted to clarify, they're not open to, externally. You would be a Bridge patient who would then go through a screening and get referred. And so Dr. Galloway was integral to that, group formation process and getting that launched. Other folks that are currently a part of that process is Dory Hansen, Michael Valdez, and Kelly Sherman. So yes, absolutely. Kudos to you, Dr. Galloway, for getting that launched and really being able to demonstrate there is a need and a want for this at a wider scale. So I'm sure that we'll be able to demonstrate that and work on getting those, offered more widely soon. So any final comments, Dr. Galloway? We so appreciate your time.
Yeah, no, I hope you enjoyed it. I know that was a lot of content. I would love to provide more and tell you more. I'm obviously excited, but I just thank you so much for everybody taking their time. And I hope that you got something out of today.
Absolutely. Well, potentially part 2, next Grand Round series, if you're up for it. Okay, we'll plug you in there. So for everybody else's awareness, we have another Grand Rounds coming up at the end of May and then another in June. We take a break for summer and we'll be back rolling in September. So yeah, hopefully 2024. Okay, we'll mark it down. All right, everyone. Have a fantastic weekend. Okay, bye-bye.